So, good morning. My name's Liz Bryan. I'm a nurse, primarily, psychotherapist, and now full-time educationalist. And it's a great honour to be here in Sao Paulo. I'm actually going to talk this morning about the modifications, quite radical in many ways, that are occurring at St Christopher's in South London. Generally recognised as the founding hospice of the modern hospice movement, but now facing many challenges. And I was, I think, reminded by Sami that we also have a two-part system in the UK. We have a national health system which is very effective, has been certainly very effective in the first 50 years since it was developed and introduced into the UK. But it's no longer fit for purpose because the burden on our National Health Service is so great that we are having to rethink how we deliver health and social care. And it is supplemented by the private and the voluntary sector, probably more the voluntary sector. And I think it's important to remind you that the 220 hospices that we have in the UK are almost all charities. They're voluntary organisations, which means that care continues to be free at the point of delivery. So there's no difference for hospice patients than there is for NHS patients. But we have to work very hard to raise the funding for those voluntary sector hospices. But even they can't now manage the full volume of those that need palliative care. So we do need to think, what models do we need now in the UK and the world? And what I think for us is very important is that St Christopher's, we're 50 years old, we're just over 50 years old. We want to share our learning so other countries and other organisations don't have to go through the same mistakes and pain that we have. So, an outline of my presentation is really around highlighting the concerns of the UK government regarding end-of-life care and the action most recently they've taken, the role of hospices, and obviously in particular St Christopher's, because that's the hospice I know the most about, and it is the largest hospice in the UK and is generally seen as the lead. And what Quelca, the programme that we've developed in recent years, is how it's supporting those changes. It's an example, I think, of our approach to education. So what challenges do we face in the UK? Now I'm going to try and do something whizzy-bang hit now and see if I can get you straight through to a publication which talks about ageing in the UK. Wish me luck. It's a little slow. It's somewhat alarming to think that if you were born in 2013, you have a 1 in 3 chance of living to 100. Those are the figures in the UK. Now, as we all know, when you live longer, you don't get more youth, you get more old age. And with old age, we get aches and pains and things are maybe not quite so easily functioning. I often talk to my students about the moment I realised that when I plucked my eyebrows, I had to put the skin back. It's a bit of a salutary moment when you realise that, yes, that old person in the mirror is you. But without exaggerating, we have to, I'm in my 60s, I have to recognise that I need to be making provision for my old age. I need to be realistic about what comorbidities I'm likely to experience because of family histories, etc. What my quality of life might be, by making sure that I live on a level. You'd laugh if you saw my house because it's like that. So clearly I need to do something about that. But I'll be, like everyone else, reluctant to admit I can't manage until the last moment. Notice that women will still live longer than men. Very interesting. But the reasons for better survival are the fact that less people are smoking, that the medical interventions for heart disease are so much more improved, and cancer treatments. So cancer is now increasingly becoming a chronic condition, which is very different from 50 years ago. And generally, we're more aware of the role diet plays in our lives. Medicalisation of dying. We have made it, and I think this, if Cicely Saunders was here now, the founder of St Christopher's, she would also accept that in her effort to involve doctors in dying, we've probably swung far too far in the other direction, so that now people really feel that they have to have a physician involved when they come to the end of their lives. And we know that actually many people have or could have potentially natural deaths. If they do need medical intervention, they don't necessarily need palliative care. They may need a palliative care approach, but they might not need hospice or specialist palliative care. So it's really important for us to think about what are the skills and understanding and knowledge that the generalists in our healthcare systems need to know so they can support aging and dying, but also how they involve our communities, society, and the whole of our communities in that whole support. We have economic constraints, which I have already mentioned. We have a really stretched system in the UK. We have austerity measures. We have, as you probably gathered, political crisis at the moment in the UK. And these things will impact on our healthcare system. What we do have, though, is our public support of a national health service. So I think ultimately it will be put to the people as to whether we would like to make greater contribution financially, because actually it's not a free system. Everyone who's employed contributes to our national health system. We have a shortage of nurses. Nursing in the UK is less popular, partly I think because of a crisis in identity. Nursing has, in its effort to become professionalised and academic, nurses have moved further and further away from the actual patient care. And that's caused some confusion around our identity. What is nursing for? What is it about? Is it a discipline or is it a role? And those are interesting debates that I'm having all over the world with other nurses. And we have a need for new models of care, which I've talked about. So what has the government done to address all these issues? Well, we've had many different publications, starting with the National End-of-Life Care Strategy in 2008, with loads and loads of different other additional guidelines, policies, all of which were saying the same thing, but actually really weren't making much of a difference. We all agree that we need better palliative and end-of-life care, but how you deliver that is the biggest challenge. But this is the latest of a number of resources. It's called Ambitions, and it very firmly puts the person in the centre of any innovations and developments. So the main ambition is, and I'll read it, and it's very much in the first person, I can make the last stage of my life as good as possible because everyone works together confidently, honestly, and consistently to help me and the people who are important to me, including my carers. So that's the ambition, and this is seen as a framework for local partners to work together to deliver good palliative and end-of-life care. So by that it'll be in regions. We have things called clinical commissioning groups, which are geographic, and the encouragement here is that partners work collaboratively to find the best way to put the patient in the centre. And there are 6 ambitions there which are named. Each person is seen as an individual, each person gets fair access to care, maximising comfort and well-being, care is coordinated, all staff are prepared to care, each community is prepared to care. And I'll come back certainly to 5 and 6. So, the role of hospices, palliative care providers. So it's important, I think, to distinguish between hospices, which I've explained are generally voluntary sector organisations, charities. Palliative care teams within hospitals will be state funded. So hospital palliative care teams work within the NHS. But they often work very collaboratively with the hospice. So on discharge from hospitals, they'll be handing over the patient to the local hospice, if there is one. Now, what are our key messages? These very much relate to St Christopher's, but the first one is, and this is not rocket science, and you'll go, oh my goodness, has she flown all the way from London to tell us this? Death is essentially a social experience with health-related consequences. Thinking about how to live and die well is a societal issue. And it feels to me, I've got more used to it, but a few years ago I felt like death and dying have been dumped on us as professionals to sort out. And actually, we need to recognise that we have to share this responsibility with society. We are society. We're going to die. Anyone in the room not going to die? Effective palliative care requires investment at several levels. And again, Dr. Samir mentioned this. The wider systems of care. We have to invest in looking at how systems work. Do they enhance care or do they hinder care? And for many of us, we're frustrated continuously with coming against aspects of systems that really don't help us to provide compassionate, person-centred care. the organisations providing care for people at the end of life. So in the UK, we are getting quite frustrated as voluntary sector organisations that are struggling to bring in the income, that actually the government is not working more closely in supporting, or at least providing something towards the cost of our services. Give you just a little bit of an example. It costs £21 million a year to run St Christopher's. We get 6 million from the government, so that's through local commissioning of services. We have to raise the rest of that through fundraising. Some of that will be local people bringing buy sales, cake sales, jumping out of aeroplanes, doing sponsored walks, etc. But that's only a very, very small proportion of our income. The rest is fundraising through trusts, national corporations, foundations, legacies, so people leaving money in their wills. It's a huge area of work in order to provide the services that we do. But it does give us autonomy. And that would be one of the messages I would have, certainly for Brazil, is just think about developing some voluntary sector services that you then have control over. The problem with always getting money from the state is that you then have targets to meet and boxes to tick and data to provide, which is quite right, but sometimes those conflict with the philosophy of the hospice. And we need to invest in the communities in which people live and die. So good end-of-life care is not just about buildings and professionals, it's actually about our whole communities. And as I say, high-quality palliative care draws in community action alongside professional care. And I've already been impressed by walking around Premier at how fundamental to the life of Premier here is the community, how involved the community are or encouraged to be. So we want a society in which citizens help each other. This is a sort of breast cancer rally. We were talking last night about suffering, and we're very interested in the whole subject of, what does suffering, how is it experienced in today's society? How we perceive suffering. Are we less tolerant of suffering? And how are we supporting one another to transition through those life stages that can be so painful? Not just dying, but... So where death is seen as part of life, where planning for end of life is the norm, wouldn't that be wonderful if we all started thinking in our adult years about our aging, our old age, and what that might look like, and what we would want if we became dependent. We want a world in which citizens feel confident to support their families, friends, and neighbours in times of serious illness or bereavement. And fundamentally, and I think this is really important, we want a world where medicine and healthcare can focus on doing what it's best at, which is redressing challenging clinical problems. So our focus needs to be on when we really are needed, but then making sure that there's a much more effective public health model, and that people start taking responsibility back. So what does that look like at St Christopher's? Well, we've just worked, we have a care transition team that have been working over the last year, 18 months, really debating what St Christopher's services should look like. And we have decided that we really should, so that top part of the pyramid, we should only be giving direct care and support to a small minority in our population, those that have got the really complex and unpredictable symptoms. However, we need to be a resource. We need to be a consultant, a consultancy for other professionals, that we can be on the end of a telephone, that we can sit in meetings, we can sit in multidisciplinary team meetings, so that we can provide the support, the role modelling, the education that our other colleagues in the national health systems needs. We want to provide public support and education. So the new building, the new learning hub is designed to be an open space where people can come in and look things up, debate. We want local community groups to use it as a venue, very much on the same lines as Premier here, but very much with a focus on enabling conversations about death, dying, aging, loss, etc. And at a societal level, how can we influence through social media, etc. So I'm just going to say a little bit about what that clinical expertise directed primarily at the complex and unpredictable might look like. Now, this slide, I'm sorry, it's difficult for you to see, but those are our values. And I'll just tell you what the values are, if I can read them. The first one is pioneering and bold. Second is of and for the community. The third is one team working together. The fourth is empowering and compassionate. The fifth is stronger through partnerships. And the sixth, and I think quite the smallest one there, is expert. Because actually increasingly we feel we have some expertise, but actually the patient and the family are the real experts. And we also need lots of expertise from our other partners in certainly other conditions. So, and just by the way, these values were developed through focus groups within our organisation, so staff coming together and actually sharing what they believed were the values of our organisation. So, of and for the community, we feel we have corporate responsibility to be a learning hub, which I mentioned before, to think about population health, to engage users, by that I mean our patients, communities, and their carers or relatives. We need also to continually think about, because we're a charity, we have to look at risk, because if we radically change our model from the traditional model, will people still want to support us? Will they still want to give their money? Will they still want to jump out of aeroplanes for this new model? And we need to be continuously collecting reliable data and looking at our clinical performance. So I mentioned last night at the meeting a suite of assessment tools called OAK, which is, we have to continuously think about, are we giving people what they need? And then for pioneering and bold and empowering and compassionate, we need to think about leadership. And by that we don't mean management, we really do mean strong leadership, thinking about our responsibility to be a voice for those that are vulnerable and who are approaching end of life. And not just those in our general community, but what about the homeless, the refugee, the prison population? Our National Health Service covers all of those people, and what end-of-life care and palliative care are they receiving? We have to think about our attitudes and characteristics around our partnerships. So we want to be confident, collaborative, trustworthy, consistent, visible, available, approachable, flexible, coaching, and insightful. So we want to be informed so that we can, and always humble. So actually there's no room for arrogance in this. We're all exploring something which is extremely challenging and emotionally uncomfortable. So, what does expert look like? What are our clinical skills? We want levels of competence in clinical reasoning, communication, expert knowledge based on evidence, assessment skills, interventions. So those are really the skills that we're developing in our consultants. So we have a number of consultants. I'm, of course, one of them. But we have clinical consultants that are doctors and nurses. And we have decided that certainly at St Christopher's there's very little difference between a doctor and a consultant nurse in their role and responsibilities. That means training people, nurses, up to a level of advanced practitioner and giving them the autonomy and support to work within multidisciplinary teams. And our strategic priorities are very much around driving innovation, empowering the public, maintaining, improving quality, ensuring, extending our reach, which is why I'm here, and ultimately ensuring that we have long-term sustainability. We've survived 50 years. Can we ensure that we survive another 50? So, we decided when we hit our 50th anniversary that we would really rethink everything. And one of the responses to all these challenges was to develop what we're going to call probably at the moment the Learning Hub, which will be a new building. It's currently being built. We had to raise the money separate to our service funding for this new building. It's going to have the most high-tech technology. It's going to have lots of flexible spaces. It's going to have clinical skills rooms so that we can bring people in to learn how to turn their mother, do mouth care, communication skills. And it's going to have a very large public space for information and a library and for public meetings. So our approach to facilitating learning is about reflecting our philosophy of care, in which we focus on the goals of individuals seeking our help. So our approach very much to education is asking learners what they're trying to do, and we'll help them to develop the skills and the understanding and to make those attitudinal changes if necessary in order to achieve what they want to achieve. And that is very much our approach. We've moved very much to a rehabilitative model of care, and our approach to training is very much participatory and empowering. So we want learners to articulate what they're wanting to achieve, and be prepared to go back into their organisation and be supported by us to make those changes through action learning. All learning needs to make sense. People have got to understand what difference their training and education will make to patient experience, why it matters, what the consequences of them not changing their behaviours might be. So Quilca, as an example of our approach, I said more last night, as I said earlier, really focusing on that ambition number 5, which is all staff are prepared to care. Now, in English, prepared has 2 meanings. Prepared as in willing, and prepared as equipped and trained and developed. And so I think it's quite significant that we focus on that and those different meanings. Certainly, being willing means that those the opportunities we have to speak to undergraduates and to talk to them about the experience of people at end of life. One way of really getting people's attention is to use stories, the stories of people who either haven't received good care and those that have received good care. So increasingly we're using, sounds terrible to say we're using, but we are certainly utilising patients and carers. So we have volunteer patients and carers who come and speak to medical students and other learners who come to St Christopher's. So Quilca is we call it an innovation in end-of-life education. It's not rocket science and none of the elements are actually new, but it's, I think the combination is distinct and it seems to have an impact. It's about bringing small teams of professionals from one organisation through the programme so that they can go back as a team determined to implement change. And we support them, so Quilca trainers will support a Quilca group over 6 months to embed their changes to their own practice, so their action plan will always apply to themselves, self, team and organisational change. It was piloted in 2013-14 with funding from the NHS or Department of Health. And Quilca is always delivered by palliative care practitioners. When it was first designed, there was concern, because I designed it, that I'm an educationalist, I'm also a psychotherapist, but I'm also a palliative care nurse. And there was concern at St Christopher's that, you know, to deliver the Quilca programme, you'd have to have all those qualifications. That is not true. We piloted it initially with an acute trust and a community team. Delivered it to one group, a colleague who had none of those qualifications except she was a palliative care nurse, delivered it to the other group. The impact was exactly the same. The most important attribute of a Quilca trainer is that they are a palliative care clinician, experienced and therefore able to work with learners in a similar way to the way that you would work with patients and families. Compassionate, empathic, person-centred, able to listen, able to not judge, all the attributes of a palliative care clinician. So in summary, it's a 5-day programme, can be delivered in 1 week, or those 5 days could be spread out over a couple of weeks or maybe 3. We suggest no more than that because people tend to have something come up and don't finish. It's really important for them to attend all 5 days, followed by 6 months action learning. There's a combination of classroom reflection, some didactic learning, but primarily day 2 and day 4 have to be out in clinical practice, observing care being delivered. They then have to come back and report to one another what they saw. Not to us as trainers, but to one another. And make sense of that. So we very much use a learning cycle of what, so what, now what. So what did you see? What did you understand? Then so what? How do you make sense of that? How do you understand it? How is it relevant to you? Is there anything here that is important for you to take into your own practice? And then the now what is, what are you going to do with what you've just learnt? As I said, delivered to small teams, no more than 8 people in a group, because it's very important to provide that intimate, safe space where people can really talk about the issues that they're grappling with. It was originally designed for nurses, but can be interdisciplinary or a group of any discipline. Right, I'm going to just try and see whether you can see this film. Hopefully you'll be able to hear it. This is the St Christopher's website, and you can see the education element. So you can all look this up yourselves if it doesn't work.
The Quality End-of-Life Care Programme, or QELCA, is an innovation in end-of-life care education accredited through City and Guilds. Designed and pioneered by St Christopher's Hospice, QELCA empowers teams of clinicians from any setting or discipline to lead on the delivery of high-quality care to patients and families at end of life.
Dying is something that you only do once. You don't get any second chances. You've got to get it right. We need to make sure that we're doing this really, really well.
QELCA integrates a work-based learning experience with facilitated classroom reflection. It's designed to be delivered by experienced palliative care professionals who've undertaken the QELCA Train the Trainers programme.
I think Train the Trainers is a way of cascading the information out to many different areas. We couldn't afford to send everybody to St Christopher's for a QELCA course, but we can train our own people, and then we can actually then run that programme ourselves. So you might wonder what this little button box is all about. I would like you all to take some buttons, just a little handful. I want you to choose a button that represents you. I want you to place around you who is going to be there when you die.
QELCA trainers, usually from hospices or specialist palliative care teams within hospitals, then deliver the QELCA programme to groups or teams from their local area. These comprise an initial 5 days followed by 6 action learning sessions. An interdisciplinary team from the Royal Hospital for Neurodisability are starting their QELCA course at Royal Trinity Hospice.
So the mixture of practical and the classroom-based learning has been really good. The classroom-based learning has allowed us to kind of reflect, learn, talk to each other as colleagues.
I hope that when we go back to the hospital, we're able to start planning in advance for people's wishes when it comes to the point that they are dying, and that we're identifying that early enough that people don't feel rushed about decisions, about what they want. We've spent a long time sort of caring for our patients and doing everything we can, and this just feels like another part of it.
We've trained a variety of different professionals through QELCA, and those professionals can come from many different areas. We can have people from specialist hospitals, people from nursing homes, GPs' practices. It's really anywhere where you're caring for patients, you're potentially caring for dying patients.
I think everyone's got a story when it comes to end of life, whether it be as a paramedic out on the road or to do with their family. As soon as I heard about the course, it was just something I absolutely had to do.
The 5 days culminates in action planning. Your QELCA trainers will support you to translate your learning into your own bespoke action plan for improved end-of-life care back in your own clinical setting. Paramedics with the London Ambulance Service are doing just that.
Carer on scene is reporting that she's very agitated.
We've been supported since the course, so we've had regular meetings and sort of brought cases to them and gone through cases, what was good, what could have been done better, and that's a real learning curve for us, and then helps us to develop to make it better for future patients.
Okay, good. So we're going to have a look. Yeah. Come on, let's go.
For a paramedic or someone in the ambulance service, it's quite unnatural not to just pick someone up, wrap them in a blanket and take them off to hospital. And we've been doing that for so long, and it's not necessarily the very best for the patient. For me, as soon as I get to a patient who's maybe actively dying or has a palliative condition that just needs additional support, the QELCA course is always in the front of my mind now. It's not always about taking the patient to a hospital, and sometimes the very best thing for the patient is to allow them to have a good death, and by that it means being at home with their friends, with their family, as pain-free as possible and as comfortable as possible.
You do need the support to keep pushing ahead, But I think that's where the action learning sets come in to help with that and to keep you on focus.
At King's College Hospital, the Quelka programme's helping to ensure those facing the end of life get the quality of care needed.
I don't want that the patients who are end of life and are dying feel that the pace is frenetic for them, and I think that we need to keep that as a focus. We need to step back, I think, sometimes from the busyness and understand how we need to slow down a bit for those patients and their families and allow time for conversations with them.
People are living longer with multiple complex conditions, resulting in significant challenges for healthcare professionals. Focusing training on the workforce is seen as the strategy to ensure that dying is managed with skill and compassion in any setting.
Before the training, I'd always had a keen interest in end-of-life issues, as I think it's so important that it's delivered appropriately and with the right level of insight, knowledge and skills. So once I'd been on the course, it did boost my confidence and allow me to deal with any issues that might arise in my clinical areas. So it definitely supported me to then support the rest of the team to work through those issues.
Only Quelka trainers who've successfully undertaken the City and Guilds accredited training and who are on the National Quelka Trainer Register, accessed via St Christopher's Hospice, can deliver the Quelka programme. Quelka Training and the Quelka Train the Trainer programmes are ensuring quality end-of-life care can be implemented in all clinical working environments nationwide.
So finally, Quelka is being delivered in various parts of the UK, but we now have international satellites based in China, in South Korea and Canada. And yesterday afternoon or evening, I was privileged to present the 3 Quelka trainers from Premier with their certificates. So we now have 3 accredited Quelka trainers here in Sao Paulo. It's now a decision as to whether you want to become a satellite and whether the Quelka would be a useful tool. I do caution that you pilot it, you try it to see whether it fits culturally. But we also have teams in Singapore, Australia and the Caribbean who are currently thinking about becoming satellites. And I think that is it. Thank you very much.